lecture is on the hip joint complex, foundations for evaluation, differential diagnosis, and prognosis. Students will learn foundations for evaluation, differential diagnosis, and prognosis of the hip joint complex, and how those foundations develop through performance and application that increases from basic recall to complex evaluation and creation. So we gotta always be thinking about how can I apply this content, okay? Or how is this content applicable to what I'm learning and what I need to do as a physical therapist? So we're going to start out by talking about the arthrology of the hip joint complex. So remember, the hip joint complex is a synovial ball and socket joint with 3 degrees of freedom. You have the head of the femur articulating with the acetabulum, often referred to as the iliofemoral joint. We talked about the iliofemoral joint being more stable than our shoulder joint. Why is that? Structure. So the structure drives the function. Just the orientation of the size ratio of the femoral head and the acetabulum, that in itself is going to contribute to that joint being more stable than our shoulder joint. Also, that joint is reinforced by strong ligaments, okay? So you have the cubofemoral ligament, the ischiofemoral ligament, and also there's another ligament that reinforces those as well. But those are your primary 2 ligaments that provide for strong stability of the hip joint complex. And then we have big, strong muscles, powerful muscles at the hip joint that provide for stability as well. On the hip joint characteristics and articulations, again, you had a proximal joint surface being the acetabulum. Someone talked about the orientation of that earlier, with it being orientated laterally, inferiorly, and anteriorly, where it also articulates with the head of the femur being a convex surface. So in the open chain, with open chain movements, we have the convex humeral head moving on the concave acetabulum. The hip joint complex has the movements, osteokinematic motions of flexion and extension, which occur in the sagittal plane, abduction and adduction, which occur in the frontal plane, and medial and lateral rotation, which occur in the transverse or horizontal plane. A capsular pattern of restriction for the hip joint complex is flexion, followed by abduction, followed by medial rotation. Sometimes medial rotation is most limited. All right, this is just a diagram of the different motions: flexion, extension, abduction, adduction, external rotation, internal rotation. Now, I will say this about flexion. All right, with flexion, you see how we get more flexion than we get with extension? But with our movement of flexion, and we talk about our osteokinematic motion. When I first flex the hip, what is my osteokinematic motion? So if I go from right here to right here, is anterior. Now say if I go into a marching position, there you go. So that's why you will see in the orthokinematics, the AK, that's why you would see the AK being posterior and also inferior slide or glide. All right. Typically with extension, look how far I can go with extension. I can't go as far unless I bend over at the trunk and try to do this right here. But typically if I stand straight up, there's no superior movement occurring. So therefore you just get an anterior glide or slide for your AK. With abduction, abduction can be a little tricky, but we do have somewhat, so depending on the range of motion. So now with abduction, we get a lateral movement, right? But we do get a lateral and starts to do what? Superior, right? So therefore, your glide is typically An inferior glide with a combination of medial. The opposite for adduction, okay? So typically with adduction, we have a movement, a medial movement of the hip off of the femur, right? So it's moving medial, and typically a lateral, maybe more so a lateral stretch per se. I'm not gonna say glide just right away, but more so a lateral and superior type of stretch, okay, with the orthokinematics. You can say glide, but some say stretch. So the loose pack position, why is the loose pack position significant? That's where we assess accessory motion. Why is accessory motion significant? So if their accessory motion is limited, then that could limit the classical motion. So we need to be looking at it. We need to be assessing it, okay? So we assess that in the loose pack position. So loose pack position of the hip being 30 degrees of flexion, 30 degrees of abduction with slight lateral rotation. And the closed pack position being full extension and medial rotation. So these are visual of those. So in this picture, this is why the therapists have those pillows to actually put the person in the loose pack position with some external rotation. And then you can see this diagram right here is a picture of the closed pack position. Now we have our osteokinematic, orthokinematic motions, and our convex concave rule. With open chain movement, we have the convex femur moving on the concave acetabulum. So therefore, in the open pack position, our OK and AK is going to occur in the opposite direction, okay? So therefore, with flexion, I explained that we have an anterior and superior swing. Therefore, you're going to get an inferior and posterior glide to occur for your orthokinematics. With extension, there's a posterior swing and roll. Therefore, you get an anterior glide. With external rotation, there's a posterior swing or lateral spin, according to some textbooks, with an anterior glide that's necessary for external rotation. With internal rotation, you have an anterior swing and roll, or some texts will say medial spin, but there's a posterior glide that's occurring. And then with abduction, I just talked about this, a lateral and superior swing with an inferior and medial glide occurring. And then with adduction, you have a medial and inferior swing with a superior and lateral glide or stretch. This is a diagram or a visual on what's occurring with hip extension, with hip abduction, with hip external rotation. Just to give you a visual, this is a superior view of the hip joint. Now, do you see how well the head of the femur fits into the acetabulum? Can you visualize that? All right, hip joint muscle actions. So with flexion, at the iliopsoas, sartorius, rectus femoris, and pectineus all play a role with hip flexion. The rectus femoris, what actually sartorius and rectus femoris, what is unique about those two muscles? Yeah, so they cross two joints, so they're gonna act at the hip and also the knee joint complex. So make sure you know those muscle actions at the hip and knee joint complex. Now the iliopsoas, we know the iliopsoas as a powerful hip flexor, right? Now this is fascinating. We talked about the iliopsoas as a powerful hip flexor, but what also does the iliopsoas do secondarily that's important at the hip? External rotation. All right, extension. So extension, we got the gluteus maximus and medius, the semitendinosus, semimembranosus, and the biceps femoris. Now, the gluteus maximus muscle, we know that's a powerful hip extensor, but it's also a powerful what? It's also a powerful external rotator. We must know that. It plays a significant role in controlling the lower extremity kinetic chain proximally. All right. deficits with the gluteus maximus muscle can work its way down the lower extremity kinetic chain. When I come over to loading response, if my gluteus maximus muscle is weak eccentrically, if it is weak eccentrically, my femur is going to rotate into internal rotation, right? Because my gluteus maximus is weak eccentrically, therefore it's not checking it. What I mean by it's not checking it, it's not controlling it, it's allowing it to go into excessive internal rotation. Now what's going to happen? It's going to work its way down the lower extremity kinetic chain. All right? Now when it works its way down the lower extremity kinetic chain, my tibia is going to do what? My tibia is going to internally rotate too. And because my tibia is internally rotating, something's going to happen at the talocrural joint and subtalar joint. What do you think is going to happen at the talocrural joint? What is my talus is going to likely do? My talus is going to adduct and plantar flex according to Dutton. I'm going to say according to Dutton. All right? You may see some other literature that could say something else. But according to Dutton, my talus is going to adduct and plantar flex. Now, what is my rear foot going to do, which is subtalar joint? It's going to pronate, okay? Now, it's going to pronate. So my rear foot is going to pronate. What are some synonymous terms with pronate? Evert, and what else? Valgus. Good. Now, what's going to happen at the forefoot? Now, this is important. We know what happens at the rear foot due to excessive internal rotation. What's going to happen at the forefoot? The opposite. So forefoot, we're going to get what? Supination. What else do we see? Yeah, supination, inversion, and varus. Okay, you can see those. Now, why in the world would these two things happen? The rear foot is going to do the opposite of the forefoot so that the feet stay flat on the ground when walking, like when in loading response and mid stance, right? All right, we got the biceps femoris, right? Biceps femoris. If it's taut, what is it going to pull the tibia? What is it going to pull the tibia into if it's taut? The biceps femoris. It's going to pull it into external rotation. But say if the biceps femoris, there's a muscle imbalance, biceps femoris is weak, all right? And your semitendinosus and semimembranosus are strong. What is it going to pull the tibia into? Internal rotation. If all of them are tight, what are they going to pull the tibia into? Flexion. Going to pull the tibia posteriorly. Again, hip joint muscle action. This is just a diagram showing the force and direction of muscle action. We got rectus abdominis. This is a fascinating muscle. We got psoas and rectus femoris all playing a role with hip flexion. What does the rectus femoris, when I contract the rectus femoris, what does it cause the pelvis to do? Posterior tilt. Then we got hip extension, then our gluteus maximus muscle and our hamstring muscles doing that. Adduction, hip gluteus medius, gluteus maximus, piriformis, obturator internis, and tensor fasciae lata. But remember I said, make sure that you know the secondary and if so, tertiary movements or actions of these muscles. So like for example, right here it says gluteus medius abduction, but what else does the gluteus medius do? Internal rotation. You need to know that. Adduction, adductor magnus, adductor longus, adductor brevis, and the gracilis muscle. So, in addition to knowing the muscle action, make sure you also go back and review the innervation. Because many of the times, if you understand the innervation of the muscles and you know the nerve that innervates the muscles, You now also know an entrapment area. All right, this is a visual. All right, medial rotation. What do we have? Tensor fascia lata, gluteus medius, gluteus minimus, pectoralis, adductor longus. And so adductor longus is primarily what? Adductor. All right, lateral rotation, gluteus maximus, obturator externus, obturator internus, piriformis, gemelli, and your sartorius muscle. Also, make sure you know the other motions or movements that the piriformis play a role with. So the piriformis is a fascinating muscle. I'm gonna spend some time on the piriformis muscle, right? So now, when I'm standing, my hip is extended, right? My hip is extended. What position is my hip in? So now, if I externally rotate, right? We already said the gluteus maximus is a powerful external rotator, the most powerful external rotator, right? But in this position, what is the piriformis muscle doing? It's externally rotating with the hip extended. So with the hip extended, the piriformis is an external rotator, right? Now, I'm gonna go sit down. I'm gonna sit right here. Whew. Now my hip is flexed, right? So you can say my hip is flexed in between 60 to 90 degrees. Now my hip is flexed between 60 to 90 degrees. What does the piriformis do with my hip flexed? The function has changed. It is now a what? It's now an internal rotator. So now I do internal rotation. Now it's contracting concentrically. So it's contracting concentrically with internal rotation. Remember when I was standing, and I did external rotation? It's contracting concentrically. So now, if I do external rotation, what is the piriformis doing? It's eccentrically contracting, it's elongating. So now I can actually stretch. That's why when we give piriformis stretch, what do we have the person do? Cross the leg over. So this puts the piriformis in a more elongated position. Then you have to lean forward. You see? So you're having to cross the leg over and over one leg and lean forward to stretch the piriformis. The seated piriformis stretch. Or when you do it supine, you have the person to flex the hip and pull the leg back and then stretching the piriformis that way. But now you got to think about, why are we having a person to go in this position to stretch the piriformis like that? It's muscle action. All right, hip joint muscle action, medial rotators, muscles of the hip joint complex, and lateral rotators. These are just visuals, right? Hip joint average adult range of motion values. So you all can compare these also with your Norton and White and compare these with Dutton. So for contracture tightness, you have your Eli test, Ober's test, piriformis test, Thomas test, tripod sign, 90-90 straight leg raise test. We will most definitely be going through majority of these in lab. Pediatric tests, Barlow test and Ortho test. We go through those in ortho and you go through those in pediatrics as well. And miscellaneous tests, like your anterior labral tear test, Craig's test, Patrick's test, which is sometimes referred to as Fabir, the quadrant scarring test, and the Trendelenburg test. We'll be going through those in lab.